Hey everybody, you are listening to The Poison Lab, a show about poisoning for people who manage poisoning. I'm your host, clinical toxicologist and emergency medicine pharmacist Ryan, and this episode is coming to you live from the North American Congress of Clinical Toxicology. I just got back from this conference, and it is always one of the highlights of my year because I get to hear about some of the most fascinating research that changes the way that we understand, triage, and treat poisonings. Now, everyone who listens to the show knows I usually put together an NACCT research highlights episode discussing some of my favorite abstracts with a group of my colleagues. This year, we're doing things a little different. I brought a microphone with me and interviewed authors of this research live right at the conference. Now, part of the fun of this episode is you get a little bit of what the feel is to be at NACCT, and that includes a little bit of background noise. So I'm going to apologize in advance to all of the listeners because you're going to hear not only my voice get continually worse throughout the episode, the effects of conferencing for 3 days, as many of you know, but also doing an interview in the middle of a big, busy crowd tends to lead to a little more shouting than you might be used to me doing during my normal interviews. And while I could reduce the background noise in editing, I could not reduce my excitement and volume, but I still think we get a lot of great discussion throughout this. Now, we're talking about research in this episode, but I wanted to touch just for a minute on the conference itself. If you're in a hurry, you can check the show notes and you'll see the timestamps of where we start talking about research, so feel free to skip ahead. Now, for the conference, I have to give a huge thank you to all the people who came up at the conference and told me they were a listener of the show and what they enjoyed about it. It's just such a fun way to get to interact with this community. I do always appreciate knowing I'm not shouting into the void. And if you ever see me at a future conference, I usually keep a couple of stickers on me just to say thank you for the listeners. The other reason I wanted to talk about the conference, because there's so much great programming that I wish I could have covered for you. We're talking a whole day on psychedelics' emerging use in medicine, a whole day on advanced supportive care in the toxicology patient, whole symposia on the granular science of things like novel antidotes, and one of my favorites, discussions of how to manage challenging cases from different perspectives, not to mention hearing new perspectives of how to manage our run-of-the-mill poisonings. Because NACCT is one of the premier international toxicology conferences, we have attendance from all over the world: the Middle East, Europe, Canada, America, South America, Australia, Asia. And it's fascinating to hear the perspectives of how people with different resources manage the same poisoning in ways that really you might never even think to do in your own setting. The perspective taking and sessions are so useful each year. I even got to moderate a really fun symposium. This conference was in Denver this year, the THC capital of the US, you might say. And everyone is dealing with increased pediatric edible THC exposure. So we brought in THC regulators, the scientific advisor for the Marijuana Enforcement Division. We brought in THC industry partners, so the chief chemist of Infused Edibles, who actually produces and manufactures edibles, and the chief of the Marijuana Industry Group. And we brought them in to talk with us as toxicologists about regulations that could be put in place to actually reduce preventable pediatric or adult exposures. We gained a ton of insight into the regulations Colorado has to ensure quality testing of their products from seed to sale, as they say, and how we could extrapolate some of those to our own states. Don't worry, all of those panelists have already agreed to come on the show, so I can share that information with a wider audience. But these are the kinds of really interesting conversations that we get to have at this conference. If you're curious about going to NACCT, at the very end of this episode, I am going to have a one-on-one interview with the president-elect of the American Academy of Clinical Toxicology, talking about what NACCT is, what you can get from it, and if you are AACT curious, as I like to call it, why you might consider going to NACCT next year. Also, if you're curious, I suggest you go to the website clintox.org, which is the website for the American Academy of Clinical Toxicology. Then you can click on the link to NACCT, and it will give you the entire schedule, so you can see all the different symposia that you get to go to. But the real reason that I go every year is for the research. This is the stuff that pushes the needle on how we actually manage patients. And in this episode, I had the opportunity to interview 11 authors of the greater than 300 research abstracts that are published at this conference every year. Now, each one of these abstracts has a number that correlates to their number in the published manuscript, which you can find in the journal Clinical Toxicology. You'll find a link to that manuscript, as well as a description and title of each abstract and their corresponding number in the show notes. So make sure you check out the show notes if you want to read more about any specific research that we talk about in this episode. We'll be talking about research that looks at shorter doses of NACCT treatment for acetaminophen overdoses, how we can individualize ECG changes for our overdose patient and use those to prognosticate, what sorts of regulations can go into place to help prevent pediatric edible exposures that have severe outcomes, how we manage acetaminophen line crossers, the people who take acetaminophen with an anticholinergic or an opioid and initially plot below the Rumac-Matthew nomogram line, but can potentially plot above it at a future date. We'll look at adverse effects from some new therapies like rivastigmine, learn about new syndromes like the Chanter syndrome in the setting of overdose. We'll find out if there is a difference in adverse effects between antivenoms, Crofab and Anavip, based on whether or not you are sensitized to alpha-gal due to Lone Star tick bites. We'll look at what the utility is of scoping patients after a caustic ingestion and what it actually helps us do. And finally, we will round it out with discussion from some amazing Australian researchers. I know Toxo's excited about that, on minimum thresholds for severe toxicity with propranolol overdose and whether or not lamotrigine should be on your differential for serotonin toxicity. All right, without further ado, let's get to our NACCT 2024 live research highlights. It is Saturday morning. It was such a fun time. Friday night, I'm off to my absolute favorite part of the conference, which is the poster session. We get to see some of the best research being performed in toxicology out on display and get to talk with the authors. I leave the session every time with new ideas for research I want to do. Stay tuned, and you'll get to hear some great research.
Ryan would like to apologize for the heavy breathing you just heard. He claims he was walking to the conference, but I think he was just excited. Let's get it started with Abstract 1. The NACCT trial.
Okay, we are here with our very first research abstract, and I know that this episode was supposed to be coming to you live, and this is live. I'm alive, and I'm here with my guest, Dr. Ansem Wong, who is live, but we are not coming from the North American Congress of Clinical Toxicology meeting. I do apologize. This is being recorded after the fact over Zoom across 2 continents. This was such an important research study, and I wanted to make sure we got to focus on it. However, both Dr. Wong and I were presenting our research at the same time, so I didn't get a chance to corner him with my microphone, but he graciously agreed to set up a Zoom with me and chat about his research. So we'll be talking about the NACCT 2 trial. And before we get into that, Dr. Wong, would you mind introducing yourself to the audience?
Thanks, Ryan. Thanks for the introduction. I'm Ansem Wong. I'm a medical toxicologist and emergency physician. I work in Melbourne, Victoria, in Australia. I'm a professor of toxicology and emergency medicine at the Monash and Melbourne universities. And my research interests are in acetaminophen overdose, and I have completed my PhD in acetaminophen overdose. Specifically, one of my major projects was the NACCT 1 trial. So today we're going to talk about NACCT 2, and I've also done a lot of other biomarker work with acetaminophen overdose. So it's really one of my areas of interest. So yeah, pleasure today to talk about NACCT 2.
We have an actual PhD in acetaminophen overdose, one of the few in the world, I believe. So we are really honored to have you here. Can you correct me if I'm wrong? I think it's you and Dr. Angela Chu. Does she also have a similar?
Yeah, that's right.
So, and she's actually going to be a guest on this show later. So we're going to have 2 maybe like the only 2 PhDs in acetaminophen overdose on this show, and I'm really excited about that. So I'm so excited about your trial, which is the NACCT trial. For the listeners, my quick takeaway is this is something that might let us stop n-acetylcysteine up to, 8 hours earlier than we traditionally do. The history of NAC dosing is kind of funny in that when it was first FDA approved, we couldn't test for acetaminophen. So the longest half-life that was ever reported in an overdose was around 12 hours. So they FDA approved a regimen of 72 hours of NAC treatment just to make sure all of the acetaminophen was removed because you couldn't test to see if there was no acetaminophen.
Yeah.
And now you could still find that protocol written in these in Lexicomp or some other, drug references, even though it's pretty outdated. And ever since then, even, the 20-hour IV protocol has been around for a long time. That was studied in 1979 by Prescott. And now we're getting more and more sophisticated. And how long do you really need to treat an acetaminophen overdose for? And that's really what you're going to help us answer, looking at a 12-hour protocol. So would you mind giving us just background, what you studied, and take us through your research?
Yeah, sure, Ryan. So obviously we know acetaminophen is one of the most common drugs taken in overdose. And as you said, Ryan, the initial 3-bag protocol was arbitrarily based on 4 or 5 half-lives of acetaminophen. And it's been a one-size-fits-all kind of regimen since the 1970s. Where we are in Australia, we use a 2-bag NAC regimen just for intro. So that's 200 milligrams per kilogram over 4 hours, and then 100 milligrams per kilogram over 16 hours. So that's what we're using as standard of care at the moment. So we're not using the 3-bag anymore because we've done multiple studies to show that it was non-inferior and it decreased the adverse effects.
Right. The 3-bag is the Prescott regimen most people are aware of. And for everyone out there, I know it's bag. It's how many doses you're getting. Sometimes it's in 1 bag. Sometimes it's in 2. I don't know. Actually, I'm curious. Do you guys actually use 2 different bags, or is it 1 bag that delivers both doses? Or is
we use 2 different bags. I think it's easier. It's easier that way as well, especially for nursing staff. They get less confused with dialing up the doses, and you get less errors that way.
Okay, just curious. But it's a 2-dose protocol, 200 mg per kilo over 4 hours, then 100 mg per kilo for the remainder of your therapy, which was traditionally another 16 hours.
Yeah. The point of the study was to see if we could make the 20-hour regimen shorter for those who are low risk of toxicity. So we did that in the NACCT 1 trial, just to recap that, which was also a 12-hour trial, but we wanted to do a larger randomized trial comparing the 2-bag short NAC regimen to the standard 20-hour.
And we will talk about the methods that you did here. For the gist of it, essentially, if you're low risk, you get 12 hours of NAC, and as long as your Tylenol is negative or acetaminophen and your liver function is normal, you're done with NAC.
Yeah.
But you kept monitoring them all the way up to that 20-hour mark and checked their AST and ALT at that point to make sure that they remain safe. So you were, comparing the 20-hour regimen to the 12-hour regimen, but still monitoring each for 20 hours. So we have the NACCT 1 trial, and then now we have the NACCT 2 trial. Methodologically, is this different at all than the NACCT 1 trial in terms of methodology, or just a larger patient?
It's a larger patient population, and the NACCT 1 trial was a control trial. We clustered the treatment, intervention, and control to different hospitals, but this is randomized at the individual level. So what we did in the study, we screened close to 3,000 patients, but we needed at least 87 in each group, which we did get. And when we put in the margin of error as well. So we got 93 patients in each group. And the intervention was the group that had NAC stopped after at least 12 hours of NAC, and the 12-hour bloods from the start of NAC needed to either have a acetaminophen concentration less than 20 and ALT less than 40, which is a very low acetaminophen concentration, and a normal ALT. And we kept them to at least 20 hours post the start of NAC and did their bloods again to make sure that they didn't develop any liver injury.
Because that's when you would normally check them in the regular protocol.
Yeah, that's right. The control group, our usual 20-hour regimen, and took their bloods at presentation, 12 hours as well, and 20 hours. So we compared the 2 groups, and our primary outcome was to look at the difference between the initial presentation ALT and ALT after 20 hours of NAC. And we showed that there was no significant difference in the median ALTs at 20 hours post the start of NACCT.
Did anyone develop hepatotoxicity?
No one who went through that protocol. No hepatotoxicity.
So this brings up kind of a question that I have. This was all, to be included in the study, you needed to be low risk, right? Like you couldn't already have hepatic injury present. It was anyone who plotted above the nomogram line who had an ALT under 40. So these are the people that we normally are going to treat for, a 20-hour protocol IV.
We also should know that there's been safety that's been built into the nomogram. So we're treating a lot of patients probably don't need treatment in the first place. And there are patients who are obviously at low risk of developing liver injury or liver toxicity. So
instead, you only treated them for 12 hours, and then you checked their hepatic function and their Tylenol. And as long as that was still normal and their acetaminophen was low enough, it was done.
Correct. And this would be applicable to pretty much, an estimation, at least 50 to 60% of patients we treat in Australia, and it would be the same in the US because we use the same nomogram line.
Right. You start at 150.
We start at 150, yeah. So I think Canada uses that, New Zealand uses that, and a lot of other countries use the same nomogram line. I think it has wide implications.
Economic impact would be huge.
Yeah.
Because we treat so many people.
Yeah, that's correct. And it's not just the time in hospital and the saving the bed. I think, it's better for the patients as well, obviously.
So this is really, really interesting. Using your data, we could potentially stop n-acetylcysteine in our low-risk patients, meaning our people who were prophylacting, we're only treating them because their acetaminophen level is high enough that they plot on the Rumack-Matthew nomogram to say they have X% chance of getting hepatic injury. So, we treat them just to be sure, and then usually they never develop it. But now we don't need to treat them for 20 hours. We could maybe treat them for 12. You're not the first study that's looked at this. We've had the SNAP trial or the Scottish Newcastle Anti-Emetic Pretreatment Protocol or the SNAP protocol, which they did 12 hours of treatment. Of course, it's got to be difficult. Their dose is slightly different than your dose. I think you guys give 250 mg per kilo in 12 hours. They give 300 mg per kilo in 12 hours. Both of you seem to split up your load a little bit.
Yeah, ours goes over 4 and theirs goes over 2.
So this is just another piece of the puzzle. A big criticism of the SNAP trial was that they treat people starting at a level of 100 in the UK. So a lot of the patients in that trial, we never would even treat here in the United States. So it's like, well, how do I extrapolate that? They eventually published a few hundred patients, a few thousand patients, many of which actually were above the 150 line. So it seems like there's tons of data now between your trial and the SNAP trial that 12 hours of acetaminophen treatment with NACCT is probably all you need, assuming that your acetaminophen level is low and your CM and your AST, ALT are low when you're stopping treatment, low or normal. One question I have is how well at-risk populations are represented in this data. So we know people who present late, they tend to develop hepatotoxicity, and we know people with massive ingestion can potentially, a lot of debate here, get, not produce or produce more NACCT than you're detoxifying. There was a trial, the Canadian acetaminophen overdose study, that looked at when AST and ALT rises after acetaminophen overdose. And I think it was something like, almost, at 15 hours or so, most people are going to have a rise, nearly 100% by 24 hours. But there is this window maybe where like an 8-hour presenter, which is kind of a late presenter, 12 hours later, you're at 20 hours and your AST and ALT are low. This happens to be one of those rare outliers where maybe they don't rise yet. That might be a missed population if they just happen to take a little bit longer to rise. Does that sound right? Or I don't know. What do you think about that?
I mean, from our study, at least I think the populations were well represented for your first question. We had early and late presenters, maybe 60% early, 40% late.
So that's so important. Okay.
The later presenters are probably even more safe because if you have normal ALTs and you're past 20 hours, post your overdose and you still have a normal ALT, you're going to be more safe than the patients who are presenting earlier. And for the massive ingestions point of view, from the majority, say 85% of our patients were within 1 to 2 times the nomogram. And the rest of the patients, some were 2 times the nomograms. There were 1 or 2 patients even 3 times the nomogram, but they were fast metabolizers and still were able to be stopped, and bloods were fine after 20 hours. So No, I think from a representation point of view, we've showed that as long as they meet those markers at the end, we can do it most people. As for the other question in regards to the outliers for the ALT rise, and I think the numbers, I think you're correct, right? From our study, as far as we can say, that it's not going to affect those patients. So,
and you know what? You actually answered that for me a little bit, because if you do have a late presenter and then you check AST, ALT at 12 hours and it's still normal, that's say 20 hours out. Your study actually continued to check the AST and ALT all the way up to 28 hours, and they all stayed the same. So that gives me a little bit of hope, at least with the power that your study is able to provide, that there is safety there. So that's great. I find all this data incredibly useful. I'm ready to jump on the train. I don't know. What do you have any future directions or even possible, limitations that you think aren't adequately covered? What do you have to leave for the listeners? Should we all be going to 12 hours, or is there more to know?
Well, I think the first thing, the listeners should consider is whether they should just go on the 2-bag NACCT regimen first, because I know there's a lot of variation, especially in the state, other places in the world, or whether people still using a 3-bag, some people are using a 2-bag. And first thing I think we should consider is just moving onto a 2-bag, because we're proven that that's less adverse reactions, that's simpler to use now. Once you're comfortable with that, then you can start considering whether you want to adopt putting in that extra bit of shortening the NACCT for the low-risk patients. Certainly, that's what we're going to be doing moving forwards at our hospitals and centers. And eventually, I'm hoping it'll get into our national guidelines. But obviously, we'll keep on studying it. Hopefully, places that have adopted a 2-bag regimen will consider using this eventually.
All right. So we have the NACCT 1, the NACCT 2 continuing to be studied. Really appreciate you providing this data for us all to use.
No problems. Thanks, Ryan, for having me. And I look forward to listening to your podcast.
Abstract number 36, ECG intervals. Does one size really fit all?
Okay, this is the first poster of the day. It's with Caitlin Roque, ND, PhD. And what is the name of this project?
The name of this project is Biological Variation of the QTC and QRS EKG Intervals. Does one size fit all?
So every time we get a tox consult, we end up getting an ECG to see if there's any QRS prolongation or QTC prolongation to say, okay, is anything interfering with sodium or potassium channels? Do we need to do any interventions? We usually use a static cutoff of 120 or 100 for a QRS and, like 500 for a QTC. But is the QRS of 120 the same for each person? So I think this project seems to answer a really interesting question. Can you use someone's baseline ECG to determine if they actually are having some prolongation, even if it doesn't meet that QRS of 120? So could you go ahead and walk me through what you did?
Yeah, absolutely. So that's exactly our question. If you have someone come in and you see their QRS is, say, 124, do they have a sodium channel blockade on board, or is that their normal QRS? Because you're pretty close to what someone would use as a universal cutoff. So our hypothesis was that the QRS and the QTC intervals are actually pretty individualized between different people rather than being normal across a population. So what we did is we took 6 healthy male participants and 6 healthy female participants, and we did repeat EKGs on them over a period of 4 weeks without any intervention. And what we found is that people's QRS and QTC intervals clustered around a certain set point that depended on the individual, but it was actually very different between individuals. And from this, we were able to compute like a reference change value, which is the amount of variation in their QRS or QTC that would be abnormal for them. And that turns out to be about 10 for the QRS. So if your baseline QRS is 120 and you come in and you're at 135, there's something going on. And it turns out to be about 7 for the QTC.
For those wondering, the QTC was calculated by the Bazette formula.
So if you have even one baseline EKG for your patient and you're suspecting sodium or potassium channel blockade, you can basically make an educated guess based on their baseline.
So if I have one ECG, basically you showed using these standard healthy controls that normal variance, it would be in like the 99th percentile distribution to be over 10 millimeters, or sorry, not millimeters, milliseconds related to the QRS. right? And you said 7 for the QTC. So you can actually do more of an individualized assessment instead of, oh, the QRS is 100. I mean, if the QRS was 80 before, that might actually be a little bit higher. So this is really cool and helps us get a little bit more granular in actually assessing the patients. What do you think about next steps? Do you think this is ready for implementation for clinical use, or what do you think about future directions for this?
Yeah, one thing that is still a question for me is if somebody's QRS is quite off their baseline, but it's not greater than the classic 120 cutoff that we use, is that actually clinically relevant? Is that person actually going to be symptomatic from another standpoint? And I think that that's like a future direction that we need to go in.
Absolutely. This is a good point to bring up. A lot of people think about the QRS when it comes to sodium channel blockade. Some of the original studies with tricyclic antidepressants by Liebelt, which is, everybody always references this R-Wave AVR study, they actually looked at a QRS of 100 back then as opposed to 120. So, the 120 cutoff might not be that effective either. So it's a good thing. This is really great research. Thank you so much, Dr. Roque, for sharing this with us. Anything else you want to end on?
No, thank you so much. It was wonderful talking to you.
Abstract number 85. Do abnormal electrocardiographic intervals predict death in poisoned patients older than 65 years?
All right, we're at poster number 2. Do abnormal electrocardiograph intervals predict death in poisoned patients older than 65 years old? We just talked about how we utilize QRS and QTC to prognosticate after exposures and how useful those really are, whether you should use strict cutoffs or individualized values. Now we're going to take a look at what their predictive value really is. And I'm here with Dr.
Mike Chari. I'm an assistant professor at Cornell, ER and Med Tox.
Thank you so much. And would you mind walking us through what you did in this research project?
This is a study using the toxic registry. And we know that the QT and QRS interval vary across lifespan. But when we, as toxicologists, worry about whether they're prolonged, we use a strict cutoff that doesn't take into account anything from not only the age, but age as a proxy for underlying disease, ischemic stuff, the effect of other medications. So what we did is we took all patients who had the recording of a QRS or QTC, the entire toxic database, and just asked, since these people are coming in and in the emergency department, you don't really know what they took, just how useful is the QRS or QTC prolongation at predicting death? And then we subdivided based on whether the patients were under 65 or over 65. So this started out with 63,000 people, ultimately including 42,000 in analysis. And we calculated the odds ratio of death if we're under 65 or over 65, given a QRS greater than 100 milliseconds, a QTC over 500. And the big takeaway is that the odds ratios as you get older are lower. So the QRS and QTC still predict mortality, all-cause mortality, whatever poisonings. You come into the ER, you have a QRS of 110, you're more likely to die than a QRS of 90. But the predictive value of that goes down with age. And so this provides the groundwork for subsequent studies that can say, well, why is there this decrease in predictive value? Is it because there's variables affecting the QRS that we're not accounting for? Is it that we shouldn't measure the QRS in every intoxication? But there's an age differential here that deserves some explanation.
And the deaths you didn't stratify by arrhythmia death versus others, all-cause death?
We didn't. There are, as with all toxic studies, some limitations. You have a benefit of a large registry study, but they don't provide the underlying EKG. We don't know the correction method used for the QT. So I think this is a broad stroke, but given the high end, 42,000 people, I think it is safe to conclude that there is an age differential in the predictive value of these EKG intervals.
Another step closer to getting a little bit more precise and understanding the prognostic value of any specific ECG variable that you're getting in your poison patient. Really cool research, and I really appreciate you joining. Anything else you want to share about future directions or messages you want to leave with the listeners?
Oh, well, the future direction for this is an ongoing study where we're looking at two things. The first is we want to, at my site, Weill Cornell, we have our own registry where we can analyze the underlying EKG. And so we can do things like use the same QT correction method, even adjust for bundle branch blocks, really look at the EKG to see what to accurately say this is a prolonged interval. And then number two, a little more flashy, we're using AI to see if we're correcting intervals in the right way.
That's pretty fun. Are you going to look at any specific drugs related to the actual prolongations, or just prolongations overall?
For now, prolongations overall, reflecting both the small numbers at a single site, and because we know that without detailed analytic confirmation, often the ER physician has to make decisions just based on the EKG, and I took something somewhere.
Very practical. Well, thank you so much for joining. I appreciate it.
Thank you for the time.
Abstract number 114. Frequency and severity of cannabis toxicity before and after legislative change to increase cannabis edible package size. And abstract number 61. Minimum THC dose that produces severe symptoms in children under 6 years old.
Okay, we're at our next poster. We are in Denver, which is the THC capital of the U.S., or at least they founded it. So a huge theme today is THC. In fact, in about a few hours, I'm talking with multiple THC manufacturers and regulators at one of our talks. So I'm here with some of the people who are doing research to help inform policy and treatment. So I have Kiahi Horowitz and Robert Hendrickson, who have done some really interesting research studies. We're going to first talk about this study, Frequency and Severity of Cannabis Toxicity Before and After Legislative Change to Increase Cannabis Edible Package Size. Real quick, Kiahi, could you give the listeners just your background and experience?
Yeah, so I'm a second-year Tox fellow up at Oregon, and yeah.
Great. All right, so this is a huge issue. We are, right now I live in Wisconsin, which is a completely Delta 9 prohibited state. But I have so much Delta 8 in every grocery store, candy shop, and gas station, and there's no restrictions on it, and people can get into 2,500 milligram chocolate bars. So I have noticed a trend of maybe increasing severity, and it looks like maybe you're going to confirm my bias with your...
Yeah, so basically this project was brought about because in April 2022, Oregon changed its legislation as far as the package size that we're allowed to sell THC, or I guess I should say cannabis edibles and other retail products. So they went from a 50 milligram limitation within the package to 100 milligrams. And we looked at the 18 months before the law changed to 18 months after the law changed to see if there was any significant change just in the number of cases of exposures, as well as if there was any change in severity. And then secondarily, we looked at if there was any change in outcomes with those same outcomes when you look at just the ones that would have been illegal, quote unquote, before the law changed. We tried to grade the severity of outcomes by basically it was mild if you had some symptoms, to moderate if you had to get some degree of intervention like in an emergency department, to severe if you had like CNS depression, seizures, kind of something more clinically dangerous, I guess you could say.
Right. So for those of you who are not familiar with poison center severity coding, severe is usually like life-threatening or disability-causing versus mild or moderate. A moderate, an isolated seizure is a moderate outcome, and that's a pretty scary thing for a child. So, these are real effects that you could potentially be seeing. So, okay.
Yeah, absolutely. The quick and dirty, as it were, was that what we found in terms of the overall exposure rate did go up. So we went from 204 to 239 exposures, and that was basically primarily driven by under 6-year-old exposures. So children were getting into this a whole lot more, about 17% increase of exposures. When we looked at the actual severity, what we ended up seeing was, I guess you could say somewhat reassuringly, that the true severe outcomes were not extremely different. They were actually about the same. They were still very present, but they were about the same. But we were seeing a lot more mild and moderate kind of outcomes. So people who are getting into a hospital and potentially needing some degree of intervention. And so then looking at it as just the ones that are greater than 50 milligrams, so after the law changed, those are now legal. Looking at that, we basically saw a very similar outcome or similar trend where we saw that the number of exposures was about the same, but then the severity outcomes, again, mild and moderate, were starting to go up over time. And I will say that this particular data was also limited by the fact that this is based on if we had a reported dose. So we don't know if there's someone who ate an entire package and just didn't tell us, and they came in and had a severe outcome, and so we couldn't get that information. So this is just based on what we could confirm as far as a true over 50 milligram ingestion.
Do you have a range of the total doses that these kids got into? Like, what was the max dose?
So as far as the kids, I think the highest one, if I remember correctly, was in the 200s. As far as the highest dose of any single exposure in this, I think we definitely saw like a 50 gram ingestion.
50
reported
grams?
Yes.
Wow.
Now that person, that was obviously an effort-based kind of thing, and it also limited by how much was, again, reported. And none of these were like we had definite packaging to confirm, but we had a very, very wide range.
So, quick take, it does seem like moderate effects are increasing. There still are severe. Related to the increased dose. That makes sense. There's a dose response curve to most drugs. You take more, you're going to see more of an effect. Do you have any granularity related to what the moderate effects were?
So I think if I remember correctly, and so it's a little hard because of all the data mining that we went through, but the moderate effects primarily were like CNS depression and or had to get a benzo in the ED for either behavioral issues, tachycardia, those kind of things.
Sure. So not necessarily clinically terrifying, but they are clinically meaningful if you have to treat a child with a benzo because of their behavior. I mean, this is really interesting, and I appreciate you sharing this with me. I wanted to also touch on everyone in the United States right now, perhaps not as much as Oregon, but we're all dealing with pediatric edible exposures. And if a child gets into, say, alcohol, which is a legal substance, they don't always get referred into an emergency department because it's legal. Well, now marijuana is legal in a lot of places, and now we're dealing with children getting into it. Sometimes clinical effects are severe, but sometimes, like in your case series, you have some children with no effects. So there's this question about triage. Does everyone always need to go in? There's a lot that goes into that. But when can I expect, based off the dose, that they're going to have symptoms? And I believe Dr. Hendrickson is going to help me answer that question. So would you actually mind giving just your background for the listeners as well?
Yeah, sure. Rob Hendrickson. I'm a medical toxicologist in Portland, Oregon. I'm the medical director of the Oregon Poison Center and fellowship director for the fellowship there.
And what was the name of your research study, or the purpose of it?
Yeah, the purpose of the study was we wanted to look at the total doses and what a child could ingest that would cause what kind of symptoms. Now, there's been some research before with like milligram per kilo dosing, which I appreciate, but this really, we were thinking about like how much should you be able to package into a package that a child could get into that would potentially have a higher risk for much more severe symptoms. And really what we found was that the most children who ingested any edible had some CNS symptoms. That's exactly what we expect. They're going to get high, basically, maybe a little bit of CNS depression, maybe a little agitation. But when you start looking at more severe symptoms, respiratory depression, seizures, those types of symptoms, that number started to go up at around 30 milligrams and then jumped up again at 50 milligrams. So, you can interpret that a couple of different ways. The way I think about it is, doesn't it seem reasonable to limit a package size to 50 milligrams and then you have an extremely small risk of seizures, intubation, severe CNS depression, those types of things. So that was sort of the synopsis of our research.
Excellent. Well, I appreciate the work that you've both done to help us all get a little bit more of an understanding on when and how to deal with these pediatric edible exposures and maybe inform some policy to prevent them in the first place. Any last comments or future suggestions, directions, whatever you may like?
No.
No.
Thank you so much.
Abstract 110. Quantification of acetaminophen line crosses in the setting of overdose with delayed gastric absorption.
All right, we're at the final poster for the first session, and I am here with the most important research, an unbelievable assessment of the quantification of acetaminophen line crossers in the setting of overdose with delayed gastric absorption. I am not biased whatsoever. It's not like this was done by my resident. I'm here with Dr. Jamie Stair.
Hi, Ryan.
Okay, so let's talk about the research project that you did. Can you tell me why you're doing this research?
Yeah, so this research is important. So this is my residency project for PGY2. We wanted to look at what really the risk was for patients that are going to cross the nomogram line if they co-ingest an anticholinergic or opioid agent.
To clarify, we are talking about acetaminophen overdoses that initially plot below the Rumax-Matthew prognostication line, and then when the lab is repeated, they plot above the line where treatment would be recommended, due to ongoing delayed absorption from an anticholinergic or opioid co-ingestion.
Because the guidelines and consensus statement will say that we need to repeat a level for those patients 4 to 6 hours later. And this does take up ED time and money and a lot of our efforts. So we're wondering how many of these patients really is it not necessary and how many might actually cross. So we're really trying to develop potentially a risk line to see who's at risk of crossing and who's not and who's safe to go home.
So what were your methods? Like, what did you actually do?
Yeah, so we it was a single center, so we used the Wisconsin Poison Center database. We collected data for 4 years of patients and included anyone that ingested Tylenol along with an opioid or anticholinergic agent that had a detectable Tylenol level between the 4 and 8 hours at the beginning, and then a repeat level to see if they could line cross.
Okay, so you had a couple of line crossers, and it looks like 172 patients, 6 people presented with a Tylenol concentration below the Romack-Matthew nomogram line, and they had co-ingested either an anticholinergic or an opioid, and then on repeat, they had crossed the line. So what could we take away from this? We had 6 line crossers, 161 didn't line cross. Is there any data that we found that could even be useful in helping? Is there a lowest level maybe that we saw where you weren't going to cross the line?
Yeah, so we actually developed our own prognostication line for those patients. So our lowest line crosser of those 6 had a 4-hour level of 86.6. So using our data, we're thinking 86.6 might be the point at which above that, those patients might line cross. Below that, it potentially could be safe for them to not line cross.
So you're saying starting at 86.6 and then following the same trajectory as the Rumack-Matthew nomogram line down, you would potentially have, you could use that maybe as a risk prognostication. Not validated, but we could start looking at that to see if that would work.
Correct, yeah, that's a start.
What an excellent foray into reducing healthcare need related to acetaminophen overdose. We do not know what to do with these Schrodinger's acetaminophen overdoses. They have both under the line and over the line, and we have no idea how to treat them. So I think this is a really cool way to start evaluating if we can change things. Thanks, Jamie.
Yeah.
Abstract 175. Cause for pause, bradycardia induced by transdermal rivastigmine in anticholinergic delirium.
It is day 2 of the official North American Congress of Clinical Toxicology, and I am at the second poster session, and we are reviewing our first poster of interest today. I am here with, could you please introduce yourself, actually?
Yes, I'm Dr. Santiago Batista Minaya. I am a second-year toxicology fellow at North Shore, Long Island, Northwell System in New York.
Thank you so much for joining us today. So I am looking at the poster, Cause for Pause, bradycardia induced by transdermal rivastigmine in anticholinergic delirium. Rivastigmine is a huge tool that many have been using now with the absence of physostigmine, although physostigmine is now importable from other countries. But physostigmine is intravenous, and rivastigmine can be given oral or via patch. So some people feel there is a bit more safety to it, actually, and it might even replace physo use in some scenarios because you can just slap a patch on someone, give them a few doses, and maybe have less monitoring. But of course, the concern becomes, well, what if their anticholinergic toxin wears off and they, say, develop bradycardia? So I've been personally waiting for the first case to show up, and I think I just found it. So could you tell me about the case, what happened, and what you think might have contributed?
Sure. So we had a 25-year-old previously healthy female that presented to the emergency department at one of our academic sites, altered, delirious after ingestion of 400 milligrams of doxylamine. Initially, she arrived tachycardic. She was delirious, alert, and oriented only to person briefly. Also had dilated pupils, dry mucous membranes, the entire classic antimuscarinic tox syndrome. She was normothermic, no urine retention. We had recommended at that point with the delirium to attempt the rivastigmine patch transdermally and apply it to the upper back. In that case, we ended up going with a 9.5 milligram rivastigmine patch applied around 10 p.m. At that point, the heart rate was actually documented to be in the 140s. 8 hours later, the next set of vitals that were performed showed a bradycardia down to the 40s. Asymptomatic. She, at that point, her delirium had resolved, was alert and oriented ×4, was able to provide more history. We had them remove the rivastigmine patch at that time, and her mental status continued to improve. Her heart rate rebounded to about 58. However, that was not her baseline. It looked like prior to some prior admissions, her heart rate was usually in the 70s. She ended up leaving against medical advice later that day, and so a little bit lost to follow up there, but definitely a big case in terms of transdermal rivastigmine and something that may be expected but has not been seen. So looking at some of the literature at this point, we saw that 12 milligrams of rivastigmine over 24 hours has led to complete symptom resolution without any adverse effects or without any recurrent anticholinergic toxicity. There was also another group that had 22 patients with anticholinergic delirium that all received the patch with a medium dose of 13.3, which is the larger dose patch. Also, nearly 70% of those also took oral rivastigmine, which with a medium dose of 6 milligrams, and no adverse events were reported in those cohorts either.
So this is actually a lower dose than was seen in any of those cohorts. So I think it's a question of, well, I have two questions. Number one, it looks like you only used a patch. At what point did her heart rate rebound? Because patch kinetics, you're actually creating basically a sub-Q depot to slowly absorb. So did she rebound right away, or was there a continued bradycardia?
So there was continued bradycardia until the time of her AMA. So she AMA'd around 5 p.m., which was 12 hours after her initial episode of bradycardia. And so her last recorded heart rate was 58.
So it does appear this is one of our concerns, and it might happen even at a relatively low dose. It sounds like it was relatively asymptomatic, fortunately.
Definitely.
And it's just something that we're going to have to continue to monitor for signals in the literature. There's people who are on no anticholinergics and get put on rivastigmine patches, and they don't develop bradycardia, right, when they're using it for the traditional uses. So this is just interesting. We'll have to learn more about who is actually at risk, and I appreciate you putting this signal out into the literature.
Of course. Thank you so much for having me. Take care, guys.
Abstract number 199. A case report of suspected opioid overdose induced cerebellar, hippocampal, and basal nuclei transient edema with restricted diffusion, also known as Shanter syndrome, with poor neurologic outcomes.
All right, we're at our next poster. I'm here with Jack Yang. Would you mind introducing yourself to the listeners?
Hi, I'm Jack. I'm a fourth-year medical student at the University of Virginia School of Medicine. Thanks for having me.
And also, we have Dr. Avery McKenzie.
I'm Dr. Avery McKenzie, one of the attendings at the University of Virginia medical toxicology program.
So we're talking about cerebellar, hippocampal, and basal nuclei transient edema with restricted diffusion, or CHANTR, a syndrome with poor neurologic outcome in the setting of suspected opioid use. I'm here because I have never heard of CHANTR syndrome before, and Jack is going to help me understand. So this is maybe an emerging constellation of symptoms that we're seeing in certain drug overdose. Can you give me some background here?
Yeah, of course. So CHANTR syndrome, this is a syndrome that was first discovered in about 2017. It's a number of radiographical findings. It is cerebellar, hippocampal, and basal nuclei transient edema, typically seen on MRI. It's associated with PCP, cocaine, and opioid use as well, often found in opioid overdose.
So if you have this on MRI, you should be suspecting drug intoxication, or is this highly sensitive? Is it specific? Do we know anything about the testing parameters of it?
Great question. As of now, we know that it's associated with it, so maybe not specific. One thing we do know, however, is that it has specific complications. One of them is the fact that patients may herniate, and a number of patients have passed away because of that. One particular treatment for this is using a EVD, or extraventricular drain, and consulting neurosurgery.
So most often, this is probably already identified. You already know your patient was a substance-using person or is potentially intoxicated, and then these findings are usually found on MRI.
And one other thing to know about CHANTR syndrome is it's something to suspect in an acute overdose patient who is not waking up as you would think they would, in the next couple of days following their overdose. If they're not waking up appropriately, I would recommend getting an MRI because there's potentially brain swelling going on in this particular pattern. And if we find it, then as Jack said, that we could consult neurosurgery. And it's actually one of few findings that we have in toxicology that we can see on on imaging that we can actually intervene upon and have neurosurgery potentially do an intervention to relieve that swelling and potentially save somebody's life.
That's news you can use. Okay, so just a quick clarification. You mentioned PCP and cocaine. So is opioid novel to this, or we see this pretty routinely with opioid too?
It has been reported with opioids before. For our particular patient, we, based on his initial presentation of somnolence, we suspect that his initial overdose was just the opioids, and the PCP and cocaine we found in his urine was probably from previous use.
Well, thank you for getting me more informed on the Chanter syndrome, something I will certainly look up more, but I appreciate getting the signal from you guys.
Thank you for having us.
Thanks for having us.
Abstract number 191. Severity scores for caustic injury. Are they even used?
All right, we're at our third poster today. It's titled Severity Scores for Caustic Injury. Zargar, they even used? I do enjoy the pun. Would you mind introducing yourself for the listeners?
Yeah, my name is Amar Chakraborty. I'm one of the second-year fellows in Minnesota.
So you are looking at the use of the Zargar scoring system by gastroenterologists after a caustic ingestion. So for a little bit of background for the listeners, if you have a caustic ingestion, largely one of the most common interventions is doing a scope where they actually look inside the esophagus to see how much damage is done. But there's kind of a question about, is that worth doing? So do you want to give us some background on this and tell me what you did for your study?
Yeah, absolutely. So for context, we're in Minnesota, and I just want to make it, highlight that because there's a fair amount of regional variability in the decisions around this. The point that we wanted to demonstrate, sort of highlight here, was the treatment pathway that the Zargar is utilized in, and it is a fragile treatment pathway from an evidence standpoint, where a single Goldilocks zone called Zargar 2B, we may use high-dose steroids and antibiotics in order to reduce the risk of delayed stricture.
Just to clarify, so the score itself, you can get like a grade 1, a grade 2, 2A, 2B, a grade 3. It has to do with the amount of injury, the circumference of injury, and the depth of the injury, but that's what that 2B comes from.
Right, and so, the treatment, the whole point of it is to decide whether or not to give this treatment. The issue we have is that the evidence for the steroids and antibiotics is already conflicted, demonstrably inconsistent. So the question of benefit is not clear. Furthermore, these are pulse steroids, often with children, necessitating a 3-day admission at least. And now we're thinking about doing again, summarily questionable treatment based on scoping them, which is also questionable. Sometimes I don't think that we need to scope these patients. Often, I would say, in order to have the GI apply this classification so that we can find that Goldilocks zone. And that's my 4-point demonstration of why this treatment pathway should be heavily questioned, summarizing the fact that 40% of our endoscopies did not even apply the Zargar score, upon which this entire treatment pathway is contingent.
So essentially, we scope so we can have the debate over whether or not we'll do steroids because we don't know if it works. And the score we need GI to use to have that debate, they're not even using anymore, exactly. Or at least 40% in your case series here. So what is the point is, I think, the point of this study, and I do appreciate that. I think this is an area of ongoing discussion. There's definitely regional variability. I know it's a debate we've had many times at our Poison Center. So I appreciate you shining a light on this, and maybe we can reinvigorate the debate in some future meetings and research.
Thanks, Dr. Feldman.
Abstract number 9. Disparity in immune-mediated reactions to the snake antivenoms Crofab and Anavip in alpha-gal sensitized patients and in alpha-gal endemic regions.
All right, it is day 3, the final day of the main Congress of NACCT, and I am so excited to get to talk about this next research project. I have cornered a past guest of the show, Dr. Ari Phillip. Dr. Phillip, would you mind just giving a quick background for the listeners on who you are and where you're working?
Hey, so I'm a toxicologist out in Arkansas. I work for the Arkansas Poison Center.
So I'm really excited about this project because if you're listening NPR, I think this is going to make a great NPR story. How could tick bites be influencing how we manage our snake bite patients? So we always have the debate of CroFab versus Antivit for many different reasons, durations of therapy, costs, how many vials are going to get used. But is there potentially a difference in adverse effects between the two? And is that potentially driven by whether or not alpha-gal is present in your population? So we're going to look at this research project that Dr. Phillip did, which is what is the difference in immune-mediated reactions between CroFab and Antivit in alpha-gal endemic regions and alpha-gal sensitized adults.
Yeah, so this is a pretty bizarre phenomenon. I almost might think of it as a conspiracy because I had not even really known much about alpha-gal until I moved to Arkansas. I'm a New Yorker, so apparently when you get bit by the Lone Star tick, which is widely distributed in Arkansas, you get sensitized alpha-gal, which is this sugar. Like a huge proportion in Arkansas, it's like 40% of people have the antibodies to this. People get this red meat allergy, ingest red meat, you get an allergy, and Fab or CroFab and Fab2, Antivip, they come from sheep and horses, and so they have alpha-gal on them. And so you get one of these antivenoms, that's coming from a sheep or a horse, you're going to potentially have a reaction to alpha-gal. And so, but we saw actually a really wild difference in the adverse reactions to CroFab versus Antivip. It was 30% adverse reaction rate to Antivip versus 5.4% for CroFab. 14% anaphylaxis rate. And our numbers, which we have some more recent data that we haven't blinded and reviewed yet, are showing actually when we average all of them together, it's closer to 40% adverse reaction rate to Antivip, which is pretty high. We're thinking about like old Wyeth antivenom data. And then so we handed our data to these really smart allergists at UVA, and they did this stuff called basophil activation testing, where basically see how well does this stuff activate your basophils and inducing an anaphylaxis-like response. And they saw there was a 144 times difference in potency, Antivip versus CroFab. So there's a pretty clear basic science correlate.
So they are taking basophils that are sensitized to alpha-gal, okay, and then they're basically exposing them to either Antivip, the drug product, or CroFab, the drug product, and seeing what their reaction is. So this is more of the benchtop confirmation of clinical findings that we're trying to see, right?
Yeah, absolutely. Thanks for clarifying that. And they actually did it in a negative control, and they had like no response to any of it. But the researchers over there, which a lot of the patients are actually researchers that happen to be sensitized or have intentionally sensitized themselves in one case. In their sensitized blood, they saw this huge disparity in the allergen-inducing potency of CroFab versus Antivip. And thanks to Nate Charlton, who helped supply the antivenom over there.
So kind of extrapolating from this, it seems there's a higher antigen load within the Antivip, just based off the findings, or maybe it's due to the dose that's given, but there is, for some reason, a higher response or more immune reaction.
Yeah, that's what seems to be the case. So there was a study a few years ago at ACMT. It was an industry-funded study that showed there was potentially some higher dose of alpha-gal in Antivip, about 3 times. But, we're seeing a pretty stark disparity. And, if you're going to get a reaction to just alpha-gal, you'd think that you'd probably react regardless. So there might be something else that's going on. So what some people wonder is maybe this huge dimeric fragment is big enough that it allows for the IgE cross-linking. That's like a prerequisite to the actual immune response. But some people smarter than me are going to have to try to figure some of that stuff out.
Absolutely fantastic. So what can I take away from this? I tell patients, if you have a tick bite, put a CroFab only label on you.
I would Yeah, I would say that if you live in alpha-gal country, consider asking if they're knowingly alpha-gal allergic. And, if you have availability of both antivenoms, consider that Crofab may have lower adverse event rates. A lot we don't understand, big caveats here, but this is what our data suggests so far.
I do have to then bring up, one limitation here. You don't know the sensitization status of the patients when they got it.
So most patients we did not, but several patients afterwards, we took 5 patients that did have an adverse drug reaction, and we checked to see if they had alpha-gal IgE titers that were elevated, and all 5 of them did.
Doing our best to tie up all the loose ends in terms of whether correlation or causation. But
That's right, yeah.
Okay. Well, thank you for sharing this research. I think it's so fascinating. Can't wait to hear about it as the next NPR special, because it's just a wild connection. So thank you.
Thanks for having me again.
Abstract number 26. Acute propranolol overdose and dose thresholds of severe toxicity. And abstract number 28. Risk of serotonin toxicity following acute lamotrigine overdose.
All right, the next abstract that we're going to cover, I'm so excited to have 2 of the best tox researchers that truly I've ever met. I think I've cited both of them numerous times, but we have Dr. Catherine Izoardi and Dr. Angela Chu, also known as the Queen of Acetaminophen, paracetamol, both Australian toxicologists and researchers. Actually, if you wouldn't mind just giving a quick introduction with your background, where you are, where you work, what you do.
Hi, I'm Catherine. I'm an emergency physician and clinical toxicologist at the Princess Alexandra Hospital in Brisbane and the medical director of the Queensland Poison Centre. So I got into tox reasonably late. I'd already been an emergency physician for about 10 years. And then I worked under Colin Page, who was my major mentor, and took over the unit after he got unwell. So my abstract is on propranolol overdose, so acute propranolol overdose and dose thresholds of severe toxicity. And it's part of the ATOM study. I'm not sure if people are familiar with the ATOM study, but it's the Australian Toxicology Monitoring Study. And so we look at different drugs in an overdose. Angela Chu was instrumental in getting this off the ground.
Hi, I'm Dr. Angela Chu. I work as a toxicologist and an emergency physician at Prince of Wales Hospital in Sydney, Australia, and for the New South Wales Poisons Information Centre. And I also am Director of Research for my hospital emergency department.
And just to orient any listeners to the ATOM studies, if you have ever, looked at giving high-dose n-acetylcysteine for massive acetaminophen, or looked at doing different dosing of your Digifab in chronic or acute digoxin toxicity, these are just some of the research that's come out of this Australian group that we use so often. Also, I think this might be, I'll apologize if I overgeneralize here, but the Hunter Areas Toxicology Service, the diagnostic criteria that most people use for serotonin syndrome, that also came out of an Australian research effort. Is that similar in the ATOM pool?
Even earlier.
That's a bit pre-ATOM. So that was mostly Jeff Spister at his group, although his tox unit is part of the ATOM collaboration. So it's 3 tox units. It's mine at PA Hospital, Angela's at Prince of Wales, and Jeff's at Calvary Mater. And then we have 2 poison centres, so Queensland and New South Wales. So that's sort of the group of sources that we get our patients from. And then we all collaborate pretty well, and we all get along. So we often try to do research together.
Just to help everyone understand that, we are very lucky to get to chat with them about their research today, because I'm sure you have cited one of their papers at one point if you're listening to this podcast. So we are going to be talking about acute propranolol overdose and dose thresholds for severe toxicity. This was a lightning abstract, which means we got to hear a little bit more about it at the conference. But this is, for me, I'm thinking, when do I actually have to worry about propranolol? We have kind of some thresholds for things like TCAs. Everyone will say, a gram is when you get worried. Well, we don't really know for things like propranolol, which can be just as scary. So can you walk us through what you did and what you found?
Yeah, we see this a lot in Australia, but we find that a lot of people are prescribing it to young girls who are a bit anxious. And so we have 10 milligram and 40 milligram tablets on both immediate release in Australia, so they're the only formulations we have. And so what we did was looked at anyone who came in after an acute overdose of at least 360 milligrams of propranolol, and then we just looked at what happened to them, what their clinical effects were, and what their outcome was. So we had about 200 patients in the study altogether, but more importantly, we had about 80 who ingested just propranolol, or maybe had it with a bit of alcohol. In Australia, people often wash down their tablets with a little bit of alcohol. It doesn't necessarily mean they're super intoxicated. So we figured that we could still consider that as our propranolol alone group. And the nuts and bolts of it, and hopefully you'll be able to read about this soon in ClinTox, but the nuts and bolts of it was that the dose threshold for severe toxicity, and we're talking about things like seizure, coma, inotrope therapy, sodium channel blockade or cardiac arrest, was 2 grams, was where we first started to see that. So even though less than that with co-ingestions, you might start to see some of those things. If it was just isolated propranolol, we started to see them once the dose got above 2 grams. Obviously, the median doses were much higher, but the threshold for toxicity in our series was 2 grams.
And this is reported dose, I assume. We can't really go back and confirm what they do.
So we have to tell you, Australians are really honest when they take an overdose. So we did have a proportion of these where we did concentrations. So we had 30 concentrations in the series of 200. And for those 30, there was a moderately strong correlation between dose ingested and concentration. But it's fascinating because my understanding is sometimes, like we teach our fellows that you believe the patient when they come through. And so we've got a number of projects coming out of ours that show these correlations with dose and effect. And because I think Australians are honest. I don't know what's going on in your centre.
That is the opposite of what they teach in America, which is the patient hath lied to you. You need to do more history because you just don't know what they took. Well, I see this as a useful tool for if I have an overdose that presents. One of the big challenges in the United States is ECMO is really a systems problem, and a propranolol is probably an ECMO potential overdose. So now if I'm seeing 2 grams as a potential ingestion, which I think I already would be pretty worried about that. But this is a great confirmation that it's a signal where maybe I do need to start thinking about moving those processes or at least letting people know.
Yeah, totally. And the other thing that we found was that in all cases, severe toxicity. So if they were going to have severe toxicity, the onset of at least one of those features happened within 4 hours. So this is another one of those poisonings that if you're talking about retrieving at 6 hours, you don't worry about it. Like the worst of it's on. Like this is something that you get sick from early, and if you can ride the storm early on, you're probably going to get through. The big ingestions that had big arrests in our group, they all actually got ROSC and stabilised fairly quickly. It was just whether or not then they got a hypoxic hit from the arrest.
That actually brings up a really good point I might need to clarify. Do you have extended release propranolol in Australia? Okay, so this is all immediate release. Okay. Well, that is super helpful. And the 4 hours, yeah, it's always nice when you get called about a really sick overdose 8 hours after it happened and they're fine. And you're like, well, I think they'll be fine. Okay. Well, thank you for sharing this research with us. I want to also talk about Dr. Chu's research study. And that is another thing for me to be worried about. Risk of serotonin toxicity following acute lamotrigine overdose. So obviously, one of the most common tox consults is like, is this serotonin syndrome? They're twitchy. I've seen some clonus, maybe, or they're altered. And usually you go hunting through the med list looking for exposures, right? A source of serotonin exposure is on the hunter's criteria for serotonin syndrome. And now apparently I need to add another thing to that list. So can you tell us a little bit about your study?
So everyone knows like lamotrigines, anti-seizure, sodium, calcium channel blockers, but so there's evidence that it affects serotonin and it affects serotonin reuptake, and it's probably a weak MAOI inhibitor. So that's what the evidence shows. So we had noticed, so actually when you go back and look at the old case series from lamotrigine, there are cases of serotonin toxicity reported, and there's one that they did 6 only lamotrigine overdoses and they report 2 got serotonin toxicity, but then they don't mention much about it. So we thought we'd look prospectively how many people are getting serotonin toxicity. Probably the issues with the old studies, it's good they did lamotrigine only, but when you start looking polypharmacy, you start to see a lot more. So we did it so Adam 9, this is Adam 10, prospectively just recruited people who took more than 2 grams, so they're pretty bigger overdoses, and they could have whatever co-ingestions they want. So there's only 13 lamotrigine only, but basically what we found is the rate of serotonin. So we had 54 patients, about 40% got serotonin toxicity, 17 moderate to severe, 4 severe. So the 3 of them needed paralysis. It was that severe. So they were rigid. The other bits that were moderate, they had basically sustained or spontaneous clonus. So they're good going serotonin toxicity. And their biggest risk factor, that didn't matter what dose they took or what their concentration was compared to the other group. It was just purely whether they co-ingested another serotonergic agent. So they were either therapeutically on an SSRI or SNRI, or they took another one in overdose. And it fits in perfectly. It's nice when the pharmacology works because it's nearly identical to what happens with meblanclamide overdose, which is also a reversible MAO. So Jeff Visbister has shown in overdose with meblanclamide, if you take it on its own, nothing much happens. You take it with an SSRI, 55% get serotonin syndrome. So it was like, oh. And so the pharmacology works, two of similar drugs, similar outcomes. So worry if you take them both together. That's what you look for it.
I'm not sure that we have meblanclamide in America, but...
So you also call it meclobamide?
Oh, meclobamide, sorry. Meclobamide.
Thank you for clarifying that. Okay, we do have meclobamide. I was like, but... so that is really fascinating. It makes sense. How was serotonin syndrome assessed? Is this a bedside toxicologist diagnosis or just any old... Because I will say I've had some cases of withdrawal, for instance, that have clonus and they're tacky and we get worried, okay, is it serotonin syndrome? But there's no exposure, and at the end of the day, when they kind of get through their worst withdrawal, they're like, nope, I just stopped taking my Xanax for however many years.
This could then be a very long answer. So this is one of my pet subjects I really like, is this serotonin toxicity. If you want to read a very long review article I wrote, you can read it in ClinTox. Is this serotonin toxicity? So I think what's really important is you have to go back one step back and you have to go, what's my pre-test probability of serotonin toxicity? That's what we talk about in the other. If I take an overdose of an SSRI, my pre-test probability is pretty high. So therefore, if I clonus or increase tone in my lower limbs, then I'm probably going to have serotonin toxicity. If I've got, which is your case, which we have that call all the time, if I'm someone with pneumonia and I'm medically unwell and I haven't had any change in dose of my serotonergic agent, my odds that I've got serotonin toxicity is not very high. So we argue actually in this review article you need more specific signs, that the Hunter criteria is too broad, and the Hunter criteria are only ever developed in overdose patients and they have just been extrapolated to everyone else, but that has caused a lot of problems. So that's what. So this group is the group the Hunter criteria are meant for. I've taken an overdose. I have a high pre-test probability I'm going to get serotonin toxicity. I get some clonus, therefore. But what happens was the ones in our units we assessed. The ones in other, obviously if we're recruiting from other hospitals we can't, but we just go through it with them. But it was pretty obvious. 17 were moderate. They were rigid, really good going clonus. I think actually the issue we probably had in the study, and it's quite hard to discern, we had 11 people have seizures. Sometimes I wonder if actually it was just spontaneous clonus being misdiagnosed as seizures, because it's happened in my own unit with the patient. They said, she won't stop fitting, and all I noticed is every time someone went past her or tapped the bed, she was intubated, she would just go into massive clonus. So the 11 seizures might not all be seizures. They could be actually severe serotonin toxicity. But don't get me started on serotonin. It's generally not like...
I appreciate the 10,000-foot expert-level crash course in serotonin. And
a very long article. My registrars do not like... We get them to... What registrars are like your trainees. I get them to read the article. They said it's very long. It is very long. It's got a point at the end of it.
I appreciate that. Well, see, it's nice because in Australia, you always know if they overdose because they're honest with you. For us... everyone's just in this quasi state of maybe they overdosed and they don't want to tell us, so we apply it broadly, and that is part of the issue that we run into. But I really like that perspective. Of course, if it's a confirmed overdose, it's much higher pretest probability, or even reported a much higher pretest probability. Takeaways from this Lamictal study: how do you think this is going to impact future care? What should I use from this?
So I think what it means is we just tell them to look out for serotonin toxicity if they've taken the 2 in overdose. We actually, when you look at all the patients, and that will be published later, actually most of them had symptoms. So we had high rates of coma, intubation. And when you look at big poison center studies, that doesn't happen. But in the few case series where it's just intentional overdose, that's what happens with Lamictal. Like you get coma and seizures are common and all that. So I think the take home, you just tell them to watch out for serotonin toxicity. Yeah. And they have a long length of stay, unfortunately. Most of them had 2-day stay.
2 days isn't too long in America.
In Australia, it's only a day. Length of stay is a day.
That is aspirational. I appreciate both of you joining. Thank you so much for sharing your perspective, and I think everyone will enjoy your research as well.
Oh, thanks.
Thank you.
All right, folks, almost to the end. And now for something completely different.
It's a bittersweet moment. It's the final day of NACCT, and I have seen my last presentation, my last poster, said goodbye to my last colleague from across the nation. But through sheer luck, I managed to lock in an interview with the immediate next president of the American Academy of Clinical Toxicology, who just so happens to be a past guest on our show, Dr. Jillian Theobald. Would you mind introducing yourself to the audience?
I'm Jill Theobald. I'm in an Uber with Ryan right now on the way to the airport. I am the medical director of the Wisconsin Poison Center. I am the president-elect of AACT, and that's it. That's enough.
I think that's quite a lot. That goes to show all of you never get in an Uber with a podcaster, or you might have an interview sprung on you. But I thought this would be a great opportunity. NACCT every year is such a fun experience, and I know I get so many different things out of it. I thought maybe it would be good to hear your perspective, as a leadership member in the society and incoming president-elect. What do you find most enjoyable about NACCT? What do you get out of this?
I find lots of things enjoyable, but I think this year my most favorite was to see all of our group from Wisconsin and all the hard work that they've put in through the years, come to fruition with their posters and their platforms, and to see how successful our first fellow graduate was, winning the CPC and doing all these wonderful other lectures as well. And so that was probably my most favorite thing. But close second is seeing all my friends that I only see once a year, and chatting with them and talking about science and geeking out over all the fun tox stuff that we get to see at the conference.
That's so fun to get to interact with people who are really touching on topics that many people don't, but we all do in some way, and it's great to get together and talk about it. So you're planning the conference for next year. If someone's thinking about, hey, do I want to get involved in AACT, what do you have to say to them?
I would have to say, if you want to get involved, please email me or any one of us that is on the board of trustees, or chat with us. If you want to get involved, there's plenty of opportunities for the meeting for next year.
You heard it here. If you want to be involved, there's a place for you. It is just really such a wonderful organization and group of people. So I hope if you've been AACT curious, dip your toes in the water. And you get to hang out with people like Dr. Theobald, myself, and colleagues throughout the entire nation. So what are you most looking forward to?
The thing I'm most excited about is seeing what our new management company can bring to the table. They have some resources that we haven't been able to tap into before. And so I think that with this transition, we're going to be able to bring some new things to the conference, which I'm very excited about. I do want to just say I'm very thankful for everybody's patience while we're working through this transition, because we are still in the process of trying to identify a place and a time for the conference for next year, but it's definitely happening.
Last thoughts for the listeners about AACT or NACCT?
I'll just say the thing I like the most about AACT is how all-encompassing it is. We have pharmacists and nurses and spies, and we include everybody in what happens with our organization, and that's one of my most favorite things about it. For anybody who's looking to come to NACCT next year, I think there's this common feeling that you're not smart enough to be a toxicologist. I feel like everybody went through that process when they were applying for fellowship or thinking about maybe doing it, but you are, and and you're there to learn, right? And everybody's there to teach each other and to learn from each other. And it is some of the best people that I know across the country. And so come, learn, enjoy yourself.
You heard it here. Come, learn, enjoy, be taught, and teach others. It's a really wonderful place to share information and collaborate. Thank you so much for your time, which I know you had no choice to give, Dr. Theobald. All right. Thank you. All right. That'll wrap it up for today's episode. Thank you so much for listening along, and I hope you got a glimpse into what it's like to attend the North American Congress of Clinical Toxicology, as well as some of the incredible research that comes out of there. We have learned so much today. The NACCT trial showed us low-risk patients might only need 12 hours of n-acetylcysteine. We found that patients have normal variation in our ECG intervals, and it depends on what interval you're looking at, but having a baseline could help you establish what is abnormal for a patient. And we also realized that if you're older, that abnormality might be less meaningful in terms of prognosticating severe outcomes. We looked at some abstracts that helped identify what doses are most associated with severe outcomes in pediatric THC ingestions, which appears to be around 30 milligrams and even more so at 50 milligrams. And we found that when your product sizes increase above those, you might have more severe outcomes within children. We looked at acetaminophen line crossers, patients who ingest acetaminophen with drugs that cause them to have delayed absorption, that is. And we found that there might be a future where we have a line crosser line where below you are very unlikely to actually cross over, and those patients might not need repeated acetaminophen levels. We found that our newest old drug, that's new again, rivastigmine, does have some incidence of bradycardia, but who gets it and why is still yet to be determined. We learned about Chanter syndrome, a syndrome that can be intervened on by neurosurgery in your patients who have overdosed on substances and are not waking up appropriately after the overdose. So it might be a reason for an MRI a few days after the ingestion. We looked at disparities in immune reactions from Crofab versus Anavip, depending on whether or not you were likely to have bitten by a Lone Star tick. And we looked at Zargar scoring after caustic ingestion and found many patients are not even getting Zargar scores. So it really brings up the question as to what the utility is of scoping these caustic ingestions when it could introduce harm and has unclear benefit. Finally, we talked with our Australian colleagues about how propranolol ingestions of 2 grams or above should make you concerned, but if it's IR, you'll probably know about that concern within 4 hours, and that lamotrigine should certainly be on your differential for drugs that can increase your likelihood of serotonin syndrome. Of course, all of the abstracts are available in the North American Congress of Clinical Toxicology 2024 abstracts, which are published in the Journal of Clinical Toxicology. And in the show notes, you can see the specific abstract number if you want to go to that reference and read it yourself. Thank you for listening today. If you like what you've been listening to, leave us a review wherever you listen to podcasts. Let us know what it is you like about the show, as it helps us reach other people interested in toxicology. You can always write into the show at toxtalk1@gmail.com, and you can follow us on social media, on Twitter at labpoison, myself at empoisonfarmd, on Instagram at tox_talk, and we do have a Facebook called The Poison Lab. You can subscribe to any of those or to the podcast wherever you listen to podcasts in order to hear about new episodes coming out. And I have to say, my absolute favorite episodes are going to be released soon. I'm getting to explore some subjects that I think are going to be fascinating to anyone who is interested in the world of poisoning or mass exposure. There's going to be a lot of fun and educational discussion. Okay, thanks for tuning in today, and I hope we can get you next time. Hey, Toxo, can you play us out?
The information on this show is for educational purposes only and should not be interpreted as medical advice or treatment recommendations. Contact your doctor for health questions or call your local poison center at 1-800-222-1222. The opinions expressed on this show do not represent those of our employers. This show is poorly written and shoddily produced by Ryan Feldman. Don't forget to give it a share with your nerdy friends. Cheerio, mates. See you next time.
I'm here with Matt Stanton. We are on our way to go to the clinical pathology competition. What are you most excited about today, Matt?
Guessing the toxicant.
We're going to see Dr. Damilola Idowu Ellisworth and Dr. Merritt Tuttle present and solve a mystery poisoning. We'll get a hot debrief with them right after the show. Stay tuned.
Great.
All right, we're here at the 3rd annual Cobalt. What's your favorite part of NACCT so far?
Cobalt.
You don't have to say Cobalt.
And other than Cobalt.